Oh, hi, welcome everyone. It's 2:30 on April 2nd. And we heard on, Jen did a walkthrough this morning on S-189. And so we have our first few witnesses in, and I think we're going to start off with Mike Fisher, the healthcare advocate. So if you remember, this is the service reduction notifications and things like that.
Notice of service reduction. Hi, I'm Mike Fisher. Happy to spend a few minutes with you talking about this issue and S-199.
189?
189.
I'm sorry.
189.
Yeah,
thank you. The chair has apologized for a number of times for the language that went into a bill last year that set us up for this. And I want to push back on that.
Mm.
I actually think it has proven to be, and at the time, there were dynamics playing out in the community. We don't need to go back into that motivated this. I wasn't sure it was worth all that much, but I've come to believe that having a regulatory process to maneuver through notice of service, service reductions is actually really important, particularly at this time. Hospitals under the current rules, under the current dynamics, have developed revenue strategies about how to balance their budgets and where to increase revenues and where not to focus on increasing revenues. And so nobody's fault, but we have over the years developed dynamics where we have hospitals that maybe are getting much of their revenue or have significant revenue coming from outpatient procedures or things like orthopedics. And maybe they haven't put as much focus on things like inpatient or birthing and so here we are today with so that's status quo. That's what's happening today. And now we have this year's hospital budget guidance that calls for a negative 1% growth. And that's after inflation, right? So it's more than negative 1%. And from the healthcare advocates perspective, that is a modest step in the right direction. And we are going to need to continue.
I know you're not the board, but you are a party to the board. Could you, for education purposes, could you advise us of the budget guidance when it took place? Because it just took place this week.
The board took its final vote on Monday this week. So it's been in draft form for a while, and there's been a lot of push and pull. And because, as you know, the board doesn't negotiate, they don't have an ability to deliberate in any other way than public. And so there's been quite a bit of discussions about it and multiple factors. But one piece of it that I'm focused on right now is the overall growth is negative 4%, and the commercial rate increase is negative 1%. Boy, there's a confusing concept.
Mm-hmm. So for both hospitals and a commercial.
Yes, and my point is, okay, that's real.
Oh, sorry, just hospitals, not commercial.
Oh, okay. I thought I heard you say, sorry.
Commercial revenue for hospitals.
Commercial revenue for hospitals. Let's get that. Not commercial rate.
Yes.
Yes. And then the next point I was going to make is, from the healthcare advocates' perspective, in order to get to a place where we be ultimately, we are going to continue to push for. We believe that there needs to be a number of more years of negative growth rates. My point is, there's going to be a lot of financial pressure on hospitals coming at us. And in that context of both how hospitals raise their revenue and negative financial pressure, how do hospitals make reasonable decisions? How do they make decisions about how to meet the hospital budget guidance? And so then switching to the community hat or even the region hat, how do we make sure that through that process, we do a good job of maintaining the things that we absolutely need in not only at the hospital, but in the region? And so I'm just coming all around to saying, I think I am convinced that a regulatory process makes sense in this space, that we ask hospitals to go through a number of steps before they make a decision to reduce a service. If
We anticipating a lot of that?
I am,
And the reason?
because of what I just described about a negative growth rate, because we don't have anybody to pay the bill. And you and I have had this conversation a few times. I like to say this, and I want to say it again. I'm the conservative one here.
You think?
I think the prospect of us spending money that we don't have is dangerous and will lead to insolvency. I am going to stand down a little bit. There's been a lot of conversation in the Senate about who should do what. Should it be what should live at AHS and what should live at the board? And I sort of in the Senate took a little bit of an outside of that role of like, this is important and it should be done well. It should be done transparently and with good notice to the communities and should be done well. Informed by what's going on in the region, and informed by the impacts on the finances of the healthcare system, informed by quality considerations, transportation considerations. There's kind of a lot to consider.
This is a stretch.
Mhm.
Do you think in any way this would help the whole idea of regionalization?
Well, I think it comes in the context of regionalization discussions. And so, parallel to this is transformation work that's going on from AHS, work engagement that hospitals have had around how they need to transform. And a lot of that conversation has been around sort of considering the regional impact. And so I guess I think that these decisions must be considered in the context of the regional needs. So I ultimately think that where the Senate came down is not bad. It is definitely a step forward to ask hospitals, to require hospitals to be doing a public process. That's an improvement. It is absolutely a step forward to be requiring AHS to consider the advisability and to non-binding to make a recommendation to say something about it, given their role in transformation. And the bill in front of you leaves the ultimate decision with the Green Mountain Care Board. I think that one could flesh out some the factors that AHS would consider as it's making this recommendation. There's a place that I think is light on some details, and I know that the board has suggested a number of different factors. I think the ones I just mentioned and maybe some more about what should be considered in this decision. But from my perspective, it's important that there be transparency. It's important that the community has an opportunity to give input, and I think it's vitally important that AHS has a role in, a public role, an official role in making a recommendation, and that we still need somebody to make a decision. And I think the Green Mountain Care Board is a good place to do that.
Okay, so in the bill currently, things that AHS shall consider.
Where are you?
I think
I'm not-
on
page two.
Jen, maybe if you're on page 2, 14, 13, starting on 13. They have to.
Consistency with statewide healthcare delivery plan
They have to
established.
analyze the reduction for consistency with the statewide plan once established. Which is again not due until 2028. The first report on it is not due, but ultimately is it 2029 that it has to be developed?
Well, I think the first name, Jen Kirby, legislative council, I think the first whole one is due to you in January of 2028.
Right.
Okay. The full statewide plan is due to us in 2028. So they have to analyze it to see if it's consistent with the statewide plan, which doesn't help this interim 2 years. They're supposed to consider what the community, how the community responded. And then make a recommendation. So really the only thing that they're really assessing before the statewide plan is whether or not the community was in an uproar or not.
And I guess that's what I'm saying, that if the committee thinks that we need the agency that's doing, I mean, I can put it more directly. The agency is involved in coming up with a plan and evaluating, I sure hope, or I believe, quality implications, transportation, impacts, costs to the system. And again, I know that Jess Holmes and maybe Emily Brown a little bit later this afternoon will go into some more detail about the factors that need to be covered. I just read that and thought that was one place that I thought was a little light on some details that the committee could consider.
And would you mind, Rick, I see Ryan, would you remind us, Act 167 and 50, why I could never 51 or 54 or 51. What were the timelines around hospital transformation? There's the Wyman report, and then it went to AHS, and AHS had to when to.
Legislative council, I haven't said that.
Right.
I mean, I think maybe all of the timelines that were actually in Act 167 have already passed. There were certain reporting that you had to get that was in 2023 largely, and then actually Act 51 provision that amended Act 167 did not really have timelines in it. It just authorized AHS to start working, or either authorized or directed them to start working with up to 4 hospitals on transformation pilot projects for transformation, but there's no timing in it. As I recall.
Thanks. Brian, do you want to ask your question?
Well, you had said something about the community, they're assessing the community's reaction to the service reduction, and that what if like a healthcare institution reduced a service and the community didn't care, but it's something that anyone who was studying demographics would understand was about to be important. You know what I mean? So where is there like a way to safeguard something from being cut, even if the community doesn't care, if there's evidence that they're gonna care next year, once it's gone, they don't realize what's about to happen. Like, there's gonna be this vast, spree of pregnancies or births or something. And, or like this outbreak of birth, and we're gonna need like more places to have babies, or, that there's gonna be like.
Then we'll need schools and teachers.
Houses.
I think that's a good point. I guess, essentially what comes to my mind is an experience that happened this summer, whenever it happened with Rutland's proposal to eliminate the inpatient pediatric unit. And boy, if you didn't attend to any of those hearings, it's worth checking in on them. The pediatric provider community showed up in force with passionate testimony, passionate perspective about the needs of their communities, the needs of being able to care for kids in the communities. And, hey, I want to recognize there may be times that things have to be done that are going to be hard. But wow, it just feels vitally important to me that we make sure that people have a voice to be heard before those decisions are made.
So that I was going to bring that up.
Mhm.
So obviously the community, and I don't want to sound disrespectful. I know I don't know, been here for 5 minutes. So I don't think that, just touching on what Brian said, I mean, the community, unless you dive deep and look at all of the hospital statistics, if that's the right word, like how many kids are seen at Rutland. I mean, of course, any community's going to worry about transportation. I mean, I know just to have my kids tested for allergies, it was a 2-hour trip. Yeah. And I get that, like, I get it. And I was thankful that I could do that. And I know a lot of parents can't take a day because that's a day, right? But for a hospital that keep the pediatric unit, when they don't see enough kids,
Right.
that needs to be remedied.
Right.
Like, how,
So I want to rerun the tape a little bit. That's why I don't think I said, or I don't want to say that decisions are contingent on support from the community or something like that. We need to hear from members of the community. We need to be informed by the community and the experts in the community. And I don't know ultimately whether it would have been or would be a good decision to close the Rutland inpatient pediatric unit. I felt really concerned that there hadn't been a good process leading up to it. But at the end of the day, there's a question of how much utilization is happening there and whether it can be staffed. There's a lot of other considerations. And so I'm just suggesting that there should be required inputs before the decision is made. Not necessarily that any of those inputs should trump
But
the
so who
decision.
makes that final?
I think that's what we're trying to figure out.
Yeah.
Oh, so it's not the Green Mountain Care.
Well, currently is,
Currently, it's the
Movie.
Green Mountain Care Board. Okay, well, well, sort of.
Why?
Yeah, I did. Wait, hold up. I got lots of questions and I'm going in order. Do you want to finish, Val? Because this was your question, so I want you to continue. And then I've got Alan, and then I've got Karen, and then I got Brian.
yeah, it's hard. I mean, I think that, and there's been a lot of dispute, about who should carry it. And honestly, from where I'm sitting, nobody wants to own it. I think everyone is afraid of being the one to make the decision. And from where I'm sitting, someone needs to be in the role of making the decision. As much as I know that I understand why the board has not wanted to do it and why the board has argued that AHS was in a better position to do it. I also feel a great deal of confidence that the board will run a transparent process where people have an opportunity to weigh in. And man, we have tasked AHS with transformation, and we've given them funding to do it, and they're in the middle of it. And so it makes absolutely no sense to me that these considerations don't have the real from that work.
Ellen,
You answered some of it, but I don't know of any community
Hmm.
that when you have a public hearing is going to say, oh yeah, I think we ought to give up this service. I don't know of any that wants to give up any program at the hospital, okay? So
You're right.
if the hospital is losing money there, they do it anyway. So you go against the will of the people.
Yeah.
And the Green Mountain Care Board is willing to make that decision.
Well, I don't know what decisions the Will and Green Mountain Care
Well,
Board is willing
and to what
to.
extent?
Yeah.
You know, what if it's a lack of doctors in a certain area of the hospital and they're losing money, but it's a very crucial part of the hospital? And all of a sudden the hospital says, nope, we'll just go do away with it because we can't find help.
Right.
I can see a lot of issues with this.
Yeah.
And I think personally, it would lead to closing of hospitals.
Hmm.
I hate to say that.
Mhm. Your points are well taken. This is hard.
Hmm.
Sharon,
First of all, I think it is good to have a procedure
Mhm.
because I feel like some things were closed and eliminated without process and maybe not for the right reasons or the right drivers. I did hear about with the pediatric in hospitals, sort of like doing heart surgery. If you don't do an IV on a infant enough times, you're not really expert enough to providing network. So I think every metric should be taken into account, including the community.
Right.
My question is for Jen. When I read this bill, I don't really see, and maybe it's in here, where Green Mountain Care Board does have the ultimate authority to make the decision. It's like the hospital,
They don't have.
the hospital does,
The
really.
hospital makes, yes.
And then Green
The hospital
Mountain
makes-
Care supervises what the hospital's decided after going through a process. Is that
Green
about
Mountain
right?
Care Board is authorized to make changes to budget to reflect the elimination or reduction.
Okay, my bad.
Thank you.
And under current law, the Green Mountain Care Board does not make the final decision. They are authorized to modify the budget and they are authorized to take other actions as necessary, but they do not have necessarily the decision-making authority over which service lines are continued or not. Depends on the extent of their hospital budget order authority.
so in 126, we said that AHS was supposed to make the decision, or
No, so in
what did we do in
126, which
126?
is what would be replaced with this, so you can
That's
see the
51.
language that it's struck.
No.
But a hospital has to provide notice, explain the rationale. The board is authorized, may evaluate the proposed reduction or elimination for consistency with the statewide healthcare delivery strategic plan once established, community needs assessment, and may modify the hospital's budget and take such additional actions as the board deems appropriate to preserve access to necessary services. That's it.
Okay,
And then anything that was part of transformation is not part of it.
So thank you. I was misreading it. I'll say,
yes.
Yes.
Well, there are many versions in this, and about S189.
Yeah.
Various parties, various roles.
I'll say again from my perspective, that I do think a decision maker has to weigh in.
Who should that be?
And I ultimately think that the Green Mountain Care Board is positioned well to do that. And I understand why they don't want to, but
Brian,
That, I'm wondering about the possibility of the Green Mountain Care Board being responsible, but not solely responsible. I know we've had this debate before about when there's one person who's not designated, then who does it? But I feel like could it be possible to ask them to take the lead, but to get legislative oversight, or maybe it's the AHS and the legislature both have to weigh in on Green Mountain Care Board's recommendation. So we're not dumping it in their lap. We're taking some responsibility and But then there's this extra piece that I just want to throw out there, which is how do you force someone to provide a service? Like, what if the hospital or the healthcare system just cannot afford to provide it anymore and does not have providers? Would you be going to start like arresting doctors and forcing them to work in labor units or whatever, or like work in mental health units? You know, if they don't want to, like, how do we make people provide the service if there isn't staffing?
Yeah, these are big challenges, and it goes to this concept that we have. I mean, do we have a plan?
Yeah, and I guess what I would say though is, I'm asking that question, but I think that the answer might be something like, what if it does come back to the legislature, we do have the power to say, we'll pay you twice as much to provide this thing. You know, we can incentivize it. Like, I feel like we don't have it would be unethical or wrong for us to force people to do something, but we can make the deal so sweet that they can't say no.
But if you don't have the numbers.
Well, we would need that from the Mountain Care Board. Like, we would need, what I'm saying is like, they would make a recommendation. Maybe it's not all in their lap. I'm not saying I have the answer. I'm just throwing out like these questions to hear from the witnesses, like what they think. But in the end, like if the Green Mountain Care Board and AHS are looking at our healthcare system and determining that this is a pivotal piece, or it's going to be a pivotal piece that we're about to lose, I think that should come to us and we should take further testimony and then decide, are we going to try to save this piece of the healthcare system? And if so, how far are we willing to go, you know? And that could mean paying more. It could mean, I don't know.
Let me just say that. So again, this is really tricky. We've tasked AHS with doing the analysis and with coming up with a plan ultimately. And hey, hospitals are doing what they can, but they trying to figure out how to run their own shop, how to make it work for them and their community. And this sort of goes to the regional thing, and we need to make sure that the individual hospital decisions fit within the region's needs, that people have access to the care that they need within a reasonable distance. And so I do think we have two parties who have different skill sets or different tasks in this system. I think AHS has taken on and been assigned by the legislature to do the planning piece, to be informed about the impacts on the system. And we have the Green Mountain Care Board with a good public process.
I'm gonna go with Leslie. Did you have a question, Leslie? And then I'll go back to Ellen.
No, more just a comment. Think about the difference between the Green Mountain Care Board and AHS. And the Green Mountain Care Board, and you've mentioned this a number of times, transparency, they have to operate with open meeting law. AHS does not. And there's a lot that goes on there that is just unknown. And that's why I think the Green Mountain Care Board is sort of perhaps the final arbiter is going to be most available to people in the community and statewide. And they have the statewide vision. Green Mountain Care Board does. Maybe once the strategic plan is done, then AHS will. I'm not sure. We don't hear about that. We don't hear too much about AHS, right? We hear a lot more from Green Mountain Care Board. So that's what I like to know about is the transparency, and that we can depend on that information to be accessible. We can watch meetings. We can, it's there. It's available to communities. And AHS it's not. And yes, we've tasked them on stuff, but.
Can I just sort of add?
But I actually wanted to ask Jen a question, but.
And I have a question.
Okay.
Witness ask questions. We've made a lot of plans. I've been around for a lot of planning efforts. Is this plan going to drive policy? Will it have a real influence over decision making? And I don't know the answer to that. But whenever I hear about a new planning effort, I think, boy, we've made some great plans in our day that have sat on the shelf.
Yeah.
And I guess I am hopeful, or I hope this isn't yet another one of those. I hope this is one that actually drives decision making.
When is the last time we focused and said, come up with a plan and the plan has come to fruition.
Sorry, I don't have to laugh.
No, it's, well, I think I mean, I guess maybe we should define what a plan is, because to me, a plan isn't a concept. A plan is, here's the plan and we follow the plan. I guess what I'm saying is, when's the last time we came up with a plan and followed the plan?
That's how you mean a plan.
Like a fire drill, maybe.
I mean, Act 167 was a plan that got executed by the Agreement and Care Board, which helped us a lot.
Yeah.
And helped the system a lot. So now we're moving on from that.
And the statewide strategic delivery plan was essentially saying, here's what we need, where we need it. Maybe. Oh, I thought Jen was like convulsing because I was getting it all wrong. You were straightening your
I don't feel like we've completed any of our plans, though. I feel like we start them and then we were like, never mind, let's do this other thing. And then we start them and then we're like, never mind, we're gonna do this other thing. It's like the house never gets finished being built because we
Well, I
keep
think, is
changing.
that okay, though? I mean, sometimes
I don't
I think
know.
that's okay.
if I recall the problem and the problem that showed up this year was we put in where they have to consider the plan, but there's no plan yet. So what are they supposed to consider? And then when they asked, what do you want us to do? They said, we don't know. We haven't come up with the plan yet. And
You mean AHS?
yeah, I mean, in
And
a nutshell, am I sort of talking about kind of what happened this year?
Yeah. I mean,
Nobody wanted to make a decision.
and further, make a plan for what the landscape's going to look like in 28. The landscape's going to look different. I mean, we can make some predictions about what it's going to look like.
That's why I'm like, it's okay to not
Do
the plan.
That it has to be
learn
iterative.
as long as you're
Yeah.
adapting and learning and.
Maybe we should call them
Finding
something
something.
different then.
Well, it depends on the unintended consequences of of what comes out of this at some point.
Alan, did you have a question?
Well, I don't know. The hospitals, nonprofit, they are a business. They run it according to how everybody's telling them how to run it. Okay. So they're losing money in a certain area.
Yeah.
They can't make that judgment of if we're going to stay afloat and we're going to keep making money, we do not need to provide this service. And all these other agencies got to get involved and say, oh, no, you go to the public. Public's not going to want to close nothing down.
Mhm.
I think we're opening up a whole can of worms here. It's their business. If this was your private business, you make those decisions. If you're not making money, you're going to get rid of that service.
Can I ask a question, which is exactly what I'm thinking about, which is exactly what you said? I mean, let's be realistic. If a hospital is losing money on a service and they're making money on a service, which service do you think they're going to cut? They're not going to cut the one that's making money. They're going to make the one losing money. And I think that the decision-making last year when we did Act 68, and we put this in here, was that the board would be able to look at that cut and make determinations on, we see that you're struggling in this area. We're allowing you to increase your revenue here so that you can keep that service. To which I was thinking, my question to you said maybe we should be coming up with more things that AHS would need to.
Factors to evaluate.
One of my frustrations in this year's and what happened with Rutland is it's very clear that that is a service that is incredibly important to that community. However, it's also a service that is losing money because you have to staff it. It's not full all the time. If it's your child, you want that there. And I totally get the importance of that. But one thing that was never asked
Rutland Regional is on a global budget with Medicaid. And these were pediatric beds. And why was AHS not saying, let's help you sustain these beds because it's important to the community to think about what they pay on a global budget for those beds? And so, you know, we had asked the Green Mountain Care Board in their role in revenue setting, rate setting, whatever they do with hospitals in the commercial space. Maybe we should be asking AHS as their, because they are the payer of Medicaid. Maybe we should be making in here that they must consider the rates that Medicaid is paying for these. And their decisions need to be made on that as well.
I mean, I think that's there's some sense to what you just said. I guess I think the Medicaid global budget's brand spanking new. But going forward, we have that dynamic. But all of this reminds me, going to Alan's question, of what I started with, a recognition that I think today hospitals care that they're making it. If they're getting paid 2 times as much for this as they're getting paid for that, but both are important in their community, it's okay, they're making it. And as financial pressure happens, if we see, I mean, from my perspective, we need hospitals in the community to do certain things that hospitals are positioned to do. And if they have been, you know, fault of years of negotiated rates, you know, they are not getting paid well for some things that we really need them to do. It would be a real loss to the community to not do the adjustment to the rates, which we're not positioned to do right now. You know, I think once we have reference-based pricing, I think there'll be some opportunities to make some, I hope there'll be some opportunities to make some adjustments. But that we have to be really careful that we don't lose the things we need the most in the community, even if it makes perfect sense for the hospital that's looking at where they're losing money today.
Trying to make the point that the reductions that we have seen consistently, I don't think it's any coincidence that they are services that are heavily Medicaid dependent. Half of the children in this state have Dr. Dinosaur. And a huge percentage of pregnant women are covered under Dr. Dinosaur. We have birthing centers. We have pediatric inpatient beds. We have psychiatric beds at. Anyways, good. Topper, go ahead. You go ahead, because I'm getting feisty.
Feisty,
I know. It's getting towards the end of the week.
I'm just speaking for myself now. But if we establish a global budget, that global budget, and it's made up the proper way, where people have input in the needs of the community, all that stuff is folded into the plan. What you have to do with the global budget is you have to fund it and keep it funded. That's what we're not doing.
But
And if you do that, it'll work. Because you know upfront how much money you're going to need to do the things that the community is saying, is showing you that they need. So if you do it, I mean, that was part of 20 years ago, a global budget in it, and I can tell you right now, it did work. And I thought we were starting it pretty well when we did Catamount Health, because then everybody had insurance. We don't follow through on things that have been well planned and with the funding that's needed, there's always something else that comes in and sidetracks it without finishing the, taking a look at really what happened. A perfect example of this is, and I know people may not know about this, but in Rochester, New York, there was an experiment that was done and on universal type of universal healthcare, and it worked. And then people got greedy and wanted more money for themselves. The project was working, people were being taken care of, and I'm just convinced that that's the way to go. I've felt that way for years, that the way to go is to develop a global budget and follow it. And make sure that people are covered. If you do that, I think the problems are solved.
Only we've listened for 20 years.
Yes, I know.
Well, it's not too late.
You make an amazing point though, Copper, which I hadn't thought about, which is AHS is already coming up with global budgets. And presumably they're coming up with global hospital budgets based upon the services that the hospital provides and the needs of the community.
Yeah.
Okay. We all set with
Can I
Mr.
say
Fisher? Yes.
Can I have one comment?
Yeah, and then we go.
And I've been here
move
for
on to
10 minutes.
Yes.
but we spent all last year doing this whole thing on certificate of need and moving some of these services out of the hospital, and I look at the low hanging fruit that I know hospitals want to get out of their dialysis, birthing centers. I know that those are not money making places, but why isn't anyone looking at setting these up outside of the hospitals? And I mean, why did we do all of that for not? If we realize that they're probably not making the hospitals any money, and we're worried about the fiscal solvency of a hospital, and we have these certificate of needs that nobody's acting on. Why isn't the hospital helping to facilitate moving some of these services out of a hospital? I just, why do we do all this and then nothing happens with any of it? That's my 10 minutes that I worked on.
Let me tell you another little story.
Yes.
Because you talked about dialysis. Prior, dialysis was done in a hospital. If you go down to New Hampshire now, where the bus there goes, because I brought Con Hogan down there all the time, they're making money.
Yes.
They're not hurting. So the system you set up there has to be some independence in that system too. And there's ways to do this. I'm hoping that what the chair was talking about comes to fruition. Many, many years ago, we said, I'll give you another example of where we screwed up and we shouldn't have, because now it's costing us more money. Autistic people. And we said, I remember I'm standing there and I remember the words being said, all of these services are going to be provided to you locally instead of you have to come down to Brandon. Well, we didn't do that. Look, the mess we're in now.
Mm-hmm.
And, we're trying to crawl our way out of this hole that we're in. We're doing some good things, don't get me wrong.
I know.
Some good things going on, little communities are being created now, et cetera, but we should have just done what we said we were gonna do, and you wouldn't have this problem that we have now. You have people aging out that can't take care of these kids, and there's no place for the kids to go. So
It is one thing to say theoretically that it would be less expensive to serve this need outside of the hospital. There needs to be a place to go. There needs to be facilities, there needs to be services set up, and significantly, we don't have that. And that might, and it, to some degree, there may be a timing aspect to that. It just might take a minute.
Mhm.
You guys been here, you've been here for 5 minutes, they've been here for 10 minutes, it might take 25 minutes. It might take,
The hospital for what it was meant to be used for.
Exactly.
I have a question and I'm saving it for our next guest.
Aha.
No, I never write anything down and I'm writing this down. Thank you.
thank you.
Thank you.
Hi, good afternoon.
Hot seat there.
I know. Feeling feisty. Has a question written down for me. I think Green Vermont Association of Hospitals and Health Systems. And do we want to start with my testimony or dive right into questions? Okay. So VAS supports S-189, the Senate version of the bill. We understand where the legislature was coming from last year and the response to the elimination of services that the UVM Health Network did at that time. We think that this bill addresses those concerns while not leaving us in a totally unpredictable spot. So we are in a little bit of no man's land where we don't have a plan and we do have these financial pressures on us. I will admit that. What this bill does is, and the main complaint I heard last year was the UVM Health Network did this and they didn't, they went public, they didn't give us a heads up. No one was notified. They did it immediately and we were unable to weigh in. I think this it ensures that hospitals will notify all the relevant parties, so AHS, Green Mountain Care Board, their own delegation, all the policymakers who could actually keep that service in the community are going to be notified before anything happens. So I think that piece is really important. It actually does give us some process so that if
Sorry.
Oh, yeah.
Okay.
Yeah. So if the Agency of Human Services said, wait a second, we need to think about how Medicaid funds the service, they have the ability to do that. I think it also provides a process for the community to weigh in, going to the healthcare advocates concerned. It does provide notification on the website and the ability for the community to weigh in, which I think is really important. I think it takes care of those two things. I think the important thing to remember also is that there's not a huge incentive for hospitals to reduce services with the way the Green Mountain Care Board is proceeding under this. So if a hospital cuts a service and that saves money, we already have in the hospital budget guidance that hospital's budget will be rebased based on that cut in the service. So it's not like the hospital will necessarily keep the money that it saves unless it can make a case to the Green Mountain Care Board that it makes sense for them to keep some of that money. So there's no big incentive, we have these budget pressures, but the budget pressure is going to remain regardless of if a service is cut, because even if it's cut, it's still the same budget on those services. Does that make sense to folks? Okay. So I think for the sort of imperfect point that we're in, where there is no plan, this fulfills the need that we have over the next couple of years, where the public is notified and has a chance to respond. Policymakers are notified and have a chance to respond.
And then ultimately, the hospital can move forward with reducing or eliminating that service if necessary, instead of ending up in this process where, again, as Representative Chena said, I'm not sure what happens. Like, we cannot, maybe rates can be raised, but if we are told that the hospital needs to keep that service and nothing changes, like, I'm not sure what happens from there. And that is really destabilizing. And so I think this sets up a good process going forward, understanding that we need to come up with a plan by 2028.
Any other recommendations that AHS shall consider when coming up with their non-binding?
I think this does,
What is the difference between just a recommendation? This is what I would want to ask Jen. I mean, by nature of the word recommendation, that's just a recommendation. It's always non-binding. Why is non-binding?
There was concern about whether anything was supposed to be done with it, so it was being clear that it was non-binding.
Okay. We have to put in a dictionary definition of what recommendation is.
Change the
Okay.
it does say, consider the community's response and the impact of the proposal on access to necessary care and services in the hospital service area. So it's not just necessarily considering the community's response. I think it's also considering that. The one thing I would change is in the last paragraph on page 5, subsection 3, it talks about authorized reduction or elimination of hospital services and
What line? Sorry.
line 5.
Okay.
And I would want to eliminate authorized at this time, given that.
Really circled that like that.
Yeah.
Okay, good.
Nothing is non-binding.
Yeah.
Okay.
So that would be my recommendation.
Is that a non-binding recommendation?
It is a I can't make Jen do anything, so it's a non-binding recommendation.
Any questions for Devin?
I know, because Devin's answered the questions that were said earlier.
Sort of to Topper's point and Wendy, Val. So we've seen a million charts and graphs. And we know that hospitals, that the increase in our healthcare spending is mainly going to, oh gosh, you're gonna hate this.
Lay it on me.
We have outpatient hospital, we have inpatient hospital. And we've seen a nice little trajectory in inpatient hospital. We have not seen this.
Right.
However, outpatient hospital, we've seen. Okay. So in the service reductions that we've seen, actually some of the also contract things that we've seen, they seem to be in the inpatient space. So my question is, what are hospitals doing? Where are hospitals investing their resources? I mean, this gets back to sort of Topper with the Brandon Training School, and we're going to do it in the community, but we have these plans, but we never actually invest in ensuring these. So where are hospitals investing their money? Are they investing in improving inpatient services, or are they investing in improving outpatient services?
I mean, I think they're looking for operational efficiencies at this point. I don't think there's a whole lot of investment necessarily happening. I think if you look at things like I'm gonna forget the term for this, but like our plant age or our sort of building age, we're one of the oldest in the country because we have foregone those investments largely. So I think we are doing things like bringing in Dartmouth and UVM patients back into our inpatient unit, and that's a lower cost for the patient. That's opening up access in those hospitals. Like, we are trying to create efficiencies on every level. And I think there is investment in the outpatient space because more and more services can be done on an outpatient basis. And we know that that's what people tend to prefer. They don't want to spend the night in the hospital if they don't have to. And so in terms of investment, you know, again, I would say we're looking at trying to reduce costs as much as possible in this moment. And that's what we're going to keep doing going forward.
Yes, Pepper.
And that may be, that may be good for UVM and Dartmouth because they're a big institution. But Central Vermont Hospital or Springfield Hospital, they may not be able to do that.
I think they are doing it. I think the smaller hospitals are doing a lot of that work. Like, if you look at Gifford, they are taking patients from Dartmouth and UVM to patients who still need inpatient care, but they don't need it in that higher cost setting. They're bringing those patients back to the community. They're staying at their community hospital, and that sort of lowers the cost of care for everyone. It's better for the patient. I think the smaller hospitals are sharing services. They're really trying to do a lot.
So, you know, some of them are. You know, I know some of them are. They're up in the north part of the city. But I just really think that the solution to the hospital's dilemma is to start off with where they are now, at the highest cost that they are now, and then develop global budgets. You're smart about it, but I think that's the way to go. And then what you've done is you've said to the hospital, you need $10 to run this show? Okay, you're gonna get it. And they run the show for $10.
Yeah.
Not 11 or 10.50. They can run it for less, but they can't go over this, the $10. I think that would solve the problem, and they'd stay in business.
I agree. We want to move towards global budgets, and you did that last year in Act 167. But on the other hand, we do have an affordability problem. And I understand that the legislature, the Green Mountain Care Board, Vermonters want hospitals to be as efficient as possible before we institute those global budgets. And that's what we're working on now. I do think the sort of process of, global budgets would necessitate a process of looking at what hospitals are keeping and letting go in terms of services, because you don't want, I don't want to get into that. Let me think about that statement more. I'm going down like a totally hypothetical road at this moment. I agree with you on the global budget piece. I'll say that.
So I don't know that I'll be very articulate, but when I look at 990s, the highest paid people in our small hospitals are orthopedic surgeons.
Yes.
So how do we think about that? Because every small hospital wants to have an orthopedic surgery service line because that's how they stay afloat. And I'm having trouble with that because then the less remunerative service lines, pediatrics, psych, primary care, whatever, gets thrown under the bus. And I don't know how to think about that. And I'd like to know how hospitals are thinking about that. And I know you're doing your transformation work and it's not for public and whatever, but how do we, I think the orthopedic service lines may be keeping places afloat that maybe shouldn't be.
Mm,
And that worries me.
mhm.
So I won't be specific, but I just don't see how we're supporting what we want since we've been spending all this time on primary care.
Mhm.
How do we move, from an inpatient orthopedic surgery center
Mhm.
all over the state to primary care, which is what we need all over the state.
Mhm.
And I'm curious to know how we do that.
Yeah, and I think we've been struggling with this for a long time, because the fee-for-service world, it sort of rewards
Yes.
that
And that's
orthopedic
come up before, of course.
thing. But right now we're focused on affordability. And I think moving into reference-based pricing and global budgets, that's the opportunity to tackle that issue. If the Green Mountain Care Board is setting the rate for orthopedic surgeons, they may lower that rate and increase the rate for giving birth or not giving birth, not getting paid for giving birth, but birthing services.
Yeah, you are.
Yeah.
Getting paid more.
So I think the hope is that the reference-based pricing will help smooth that out a little bit. And then the opportunity with global budgets is if a hospital understands that it is working within a budget, then it can really focus on those essential services for its community instead of chasing the fee-for-service model.
But that likely the fee-for-service model for orthopedic surgery isn't going to change. I don't imagine. I mean, do we imagine that's going to be included in a global budget?
If Medicare was playing, but that's obviously up in the air with the AHEAD model.
Daisy has a question, but do hospitals know on a micro level how much like that one orthopedic surgery costs to provide that care? Or say, like, how much does one birth per birth? Do all of our hospitals have an analysis of exactly what it costs to provide a care? How much does it cost to provide an abdominal CT? How much does it cost to provide? Do we have that?
That's not the charge master, right? You're saying
It's not a charge
Okay.
master.
The charge master.
I will check and get back to you on that.
I'm just wondering how the Green Mountain Care Board is ever going to be able to set reference-based pricing to incentivize the kind of care that we need once AHS finishes the statewide strategic plan, if hospitals don't even know how much it costs to provide that care in the first place.
Well, they must know. I mean, we know what they're paying orthopedic
They put their
surgeons.
budgets.
I mean, their budgets, they must have that information. I mean, maybe not every knee replacement costs exactly the same in every moment at one place, but they must have an idea. I mean, they're charging.
Well, that's what I'm wondering is if we get that data.
That's why I asked about charge master.
Our critical access hospitals are at cost. They have a cost report.
Okay. Daisy?
How often do hospitals do community health needs assessment?
Every 3 years.
And can you tell us a little bit about what's contained in there?
Sure. I'm delving back into my memory. I believe it has the needs of the community. So the surveys are done within the community to figure out what the needs are. And some of those are done at like town meeting day, those surveys are given out, that sort of thing. And then a prioritization of those surveys once they come back, and then a plan for how the hospital either can or cannot meet those needs.
And is it like personal individual health needs or is it community-wide health, like economic needs?
Yeah, that's a good question. I'd have to go back and look at the surveys that are done. I'm not sure. I would have to go back and look at that. And I can certainly check the I can give you the website where all the community health needs assessments are.
I can Google it too. I just,
Okay.
the first page of the bill refers to that and, realized we never really dug into. it.
Yeah.
Yeah, no, they're really,
Actually, yeah.
they're great. There's a lot of good information in there.
Go ahead, Val.
All right, I might edit. So reference-based pricing. Would the Green Mountain Care Board, would that be across the state or would that be per hospital?
I don't know. Because it
Well,
hasn't,
I'm worried if one hospital, like we've seen it, charges more for a service to make up for the loss somewhere else. I mean, how could that not be really bad if it's just the same,
right.
right?
That's the peer.
My understanding is that the Green Mountain Care Board has said that it will take into consideration different types of hospitals. But the Green Mountain Care Board is here, so they can talk a little bit more about their reference-based pricing work.
Have we, let me ask Diane. Have we, I feel like reference-based pricing is like in my head all the time. And I can't remember if it's other conversations. Have we had an update from the Green Mountain Care Board? And when I say the Green Mountain Care Board, I mean Elena. Have we had an update from Elena on reference-based pricing yet? Or were we saving it?
Diane Lampert, Green Mountain Care Board. When the reference-based update was due was in February 15th, that we turned in the report and Elaine or somebody came in to give you an update on where that was.
And we had that update?
Yes.
Okay.
It feels like a long time.
It does.
Yeah, I'll read you through, I'm looking at Act 68 at some point and like how they, because it's all in development right now. No more questions for Devin. I just have one last one. Didn't even write it down. I was gonna say, I think if I'm not mistaken, I think that March 15th, there was a report due on hospital transformation from the hospitals to AHS.
Mhm.
Has that been delivered and have we seen that?
I have not seen it. And my understanding was there was the earlier report due in February from the hospitals to AHS, and then AHS was sort of combining a lot of those reports into this report on March 15th, but I have not seen that yet.
Okay.
And I would add that,
We would love to see that on it.
yeah, we're in a little bit of the funky position with the antitrust piece where we can't be in the middle of that. And the state needs to be.
Okay. Daisy, did you?
Yeah, I'm curious, and sorry if I missed it, but are we doing anything with the rural health transformation around to look at actual cost of care? Are we doing any cost analysis with those dollars?
I don't know.
It just seems like we could.
I think that's a good question for AHS.
Thank
Thank you.
you. Thank you. Thanks, Devin.
Thanks.
You're actually kind of lucky that you're going last because I'm getting tired.
Okay. Don't get my hopes up. Thank you for having me, Emily Brown, Green Mountain Care Board. And before I start, I do just want to say a big thank you to Representative McFawn. I understand
your last day is tomorrow, and I just want to thank you for your service. I've been in this committee in various roles for a while, and I just really want to thank you for what you've done for this committee and healthcare in the state. So thank you. Yeah. Okay, so to start, so the original version of this bill originally had the duty of approval of the transformation, or sorry, of the reductions or eliminations with AHS. The Green Mountain Care Board supports the original version of this bill. The original version also still had the hospital process where they had to provide notice and the public engagement process. We think that's very important. So we're happy that that made it into the Senate passed version. But we do strongly support AHS having the requirement to approve any reduction or elimination. And there's a few reasons why that is. So as I think has been discussed throughout this testimony, AHS currently at this moment has the resources and the duty to transform our healthcare system. They have the Rural Health Transformation Funds, which is going to amount to $1 billion over 5 years. They are receiving transformation plans as we speak from hospitals. They are in charge of developing a statewide strategic plan. All of those things go to how is our system going to look? And they are the ones who are directing that work. The way that the law currently exists, not talking about the bill, but the existing law currently, has the Green Mountain Care Board looking at any service line reductions or eliminations. The first and last time we went through that process, it was quickly apparent that the board was operating in a vacuum of information. We did not have the resources, meaning the financial or the staff resources, to do the analysis that is required to truly understand the impacts of a service reduction or an elimination. Again, that has been a decision that was made by the legislature to give that authority, at least to the regionalization, the transformation, as I talked about, to AHS. So by having the board do their own analysis, we're essentially operating in a silo and do not have the perspective or the benefit of having the perspective of what is the plan for the state. If the board was required to continue to approve or deny any service lines reductions, we will still be requesting information from AHS and asking for their input. We actually did that during the Rutland case, and we're not able to get any input or information from AHS to inform our decision. That's, to me, very problematic, not only for our decision-making, but for the state as a whole. I don't think it's good for the board to be making a decision in isolation that could have huge ramifications and potentially be out of line with what AHS is planning for their transformation efforts. So we would recommend that if the committee was willing for AHS to have a positive requirement to make a decision around any reduction or elimination. So that's kind of where I wanted to start. As to the Senate passed version of this bill, as I said, we support the notice provisions. Some points I wanted to make were about timing. So it's very clear at the beginning of the bill in subsection A, or I believe that's subsection A, around the hospital process and what they have to do. What was not clear to me is that once they're engaging in their public process, that the Agency of Human Services shall, and then there's requirements, analyze each proposed service reduction or elimination, consider the community's response, provide non-binding recommendations. There is no definitive timeline of how that non-binding recommendation is then feeding back or at all into the hospital's decision. The hospital is required to provide the notice 60 days before a closure. There's nothing that says that AHS has to finish their analysis or complete their analysis before then a hospital is making a decision to close. So I think just wanted to point that out, that I think there could be, I imagine this analysis is not a very quick thing to complete. So I just wanted to point out that it wasn't clear to me if that was the intent of to have the hospital engage in their process and then give AHS it. And I think that it should be timed. I think it wouldn't be fair to hospitals for AHS to have an open-ended timeline to do analysis. I think there does need to be some timeliness there, but I think it's not clear in the language, and Jen, please correct me if I'm wrong, that analysis will then be feeding into or informing the hospital's decision.
What kind of timeline are you thinking?
I don't have one in mind, and I am hesitant. I would want AHS, if they're the ones doing the analysis, so I wouldn't want to recommend something, but I just feel like that is kind of a missing piece here. And then the other thing I wanted to point out was there is this requirement for upon receipt of notification from the hospital. So that's the notification from the hospital that then is informing the board's budgetary decision. There's no assumption here that AHS's non-binding recommendation will be informing the board's notice. So again, this is more of like a timing issue. I think it's important that upon notice and receipt of AHS's non-binding recommendation, if that is the language that is the preference of the committee, that those two things are informing the board's budgetary process, not just the notice from the hospital. And then one more recommendation as well. On page 5 of the bill, line 4, this is existing language that requires the board to collaborate with DFR and monitor the implementation. I realized there was a strike of the word authorized. The board would recommend striking that whole section. We don't believe that collaboration with DFR as far as this function is really necessary or would really add value to this process. So that's our other recommendation for this bill.
This existing law says that the board, am I reading that right? Because it's not underlined that's existing.
Correct. That's my understanding.
Collaboration with DFR should monitor the implementation of any authorized hospital services. So to determine its benefit.
Right. DFR does not oversee costs
now.
It did not.
Authorized decrease.
Okay. Oh, right, because that decrease was struck.
Oh, okay. Okay,
So-
that makes a difference a little.
Yeah, so the language as it says, any authorized reduction or elimination of hospital, DFR does not oversee hospital services. And to my knowledge, and I'm happy to hear otherwise from DFR, determine its benefit to Vermont or the healthcare system. I think there's obviously language in here that talks about any budgetary decisions related to reductions or eliminations flowing through to insurance premiums, which we regulate through our rate review function. But we don't believe that this collaboration or requirement to collaborate with DFR is appropriate in this, if this is the language that the committee intends to pass. So.
Hi, Daisy, you seem to be pondering, is that a
I'm thinking if you did anything in 585, that this.
Oh, yeah. Yeah, we didn't,
The DFR bill.
Right, but as far as
It would change the, perhaps their need to or desire to collaborate with DFR. I don't think so.
go ahead, Brian.
Did you have an opportunity to present these amendments to the Senate?
Yes, so in the Senate, we were asked at the beginning to testify several times, and we testified exactly how I just testified, that we supported AHS having the role of approval or disapproval of reduction. Essentially the same thing I just said, correct?
And they didn't do it?
They did not do it.
Yeah, I'm not gonna ask you why it's not fair, but I am curious for us to know why they didn't do it if they were asked to do it by Green Mountain Care Board.
You should. Yeah.
Okay, all right, thank you. Yeah, I'm not asking you.
I see Val has a question, but first of all, do you think you could have your suggestions and send them to us?
Yes, I can do that.
Along
Thank you.
with CCing our legislative council?
I'll do that.
Thank you. Because if you send it to me, it'll never end up with the agenda. I have a question, and Val has a question. You said, and I've been here long enough now.
20 minutes.
I've been here 25 minutes. And in my first minute, and then my second minute, and my third, I remember, so Act 167, Act 51. And you said that AHS has been given the resources, the appropriations, the positions to carry out the work that we've tasked them to do. And I'm particularly thinking about the hospital transformation work. Let's leave the statewide strategic plan out of it. So we first gave the Green Mountain Care Board the resources to be able to commission the Wyman report. That was done. That was a process. And then it was passed on to AHS to not come up with a transformation plan, but to actually do transformation. Do you think that if given the resources, that we should move it back to the Green Mountain Care Board?
So,
With the appropriate resources.
yeah,
Because you do regulate hospitals, and this was about hospital transformation.
regulate hospital budgets.
Hospital budgets, yeah, great. You have a role in the hospital budgets, and yet we've sort of moved away like any ownership from the board of like having influence on hospitals, which is what the transformation plan was supposed to be.
So I can't, that was before my time at the board. I can't speak to that, and that was a legislative decision. Just a few points, where we are now, right? We have the Rural Health Transformation Fund money coming in. That's a huge amount of money that AHS has the authority, the spending authority over. So that is to encourage transformation, to enable transformation. AHS is also a payer, as was mentioned before, right? They have control over Medicaid payments. If we are wanting a well kind of rounded and kind of well-informed decision-making, I think it's important to have the people at the table doing it have different perspectives and various perspectives on that work. And I think, again, if I look at AHS, the fact that they're a public payer, they're the ones kind of leading the Rural Health Transformation Fund work. It does make sense where we are now to have them lead this work. I can't speak to back when after Act 167, there was a decision made to transfer that. I don't know if at this point in time, it would make sense from an efficiency standpoint and a lot of points to move it back to the board. We are where we are. I think there's opportunity for us to work together on this stuff. Like this impacts our work, right? But as far as who is directing and owning the work, I think it makes sense to be at AHS because of where we are right now. If we were having this conversation maybe 4 or 5 years ago, that answer might be different. But I just feel like where we are right now, it makes sense to proceed as we are and have AHS doing the transformation work.
I think I just continue, I see you, I think Val had a question, and then Karen, just continue to be frustrated in my 25 minutes that I've been here. It seems as though every single bill is a decision-making process over who's going to do what and who's going to work in collaboration with or consultation with. And it just feels, I don't know, it feels like the state of Vermont doesn't have a mechanism for putting out a plan and implementing a plan and moving forward with plans. I thought I was over being feisty. I'm not. You don't need to comment on that. I guess I'm just, it just feels like we have the same conversations over and over. Val.
Go back to page 1. I just was hoping you would repeat.
Yes, but I apologize for not having written.
You had mentioned a positive requirement of someone to do something.
So what I was referring to is in the original version of the bill that was introduced in the Senate, there was a requirement for AHS to say yes or no if there was a reduction or elimination. So they had the duty to approve or deny any reduction or elimination. Currently, I think Jen read through some of the existing language. It's a vaguer standard right now with the board. It goes through our process and we may take action and take appropriate action as we deem necessary. The original Senate version had language that was essentially put the burden on AHS to make a decision around whether a service should be eliminated or reduced.
Go ahead, Karen.
I'm channeling, I've only been here 5 seconds. And I'm channeling Chair and Vice Chair. When I think of the Green Mountain Care Board, I think of an entity that's at this point in time functioning well, having the tools to function well, very clearly identified, and having expertise, all of it. And when I think of AHS, what comparable entity there could possibly be the funnel or the conduit to to take on this responsibility? It seems large and amorphous, and I don't have that same. And I don't know when you say AHS, what?
Yeah. So it's my understanding, I don't want to testify on behalf of AHS. That is definitely better suited to them, but they do have the Director of Healthcare Reform. In the Office of Healthcare Reform lies within AHS. So it's my understanding that area is part of who's leading this work, but I don't feel comfortable testifying on behalf for them. So that would be better suited to them.
But you're clearly saying they should do it, and I don't want you to speak for them either, but
Yes. So maybe I can give a little bit more depth to that answer. We are a staff of about 30, and we already have a very labor-intensive hospital budget process. We have rate review. We have our ACO and CON review. We do a lot with very little, I would say, having experienced other departments and agencies in the state of Vermont. We are I would say a very high functioning entity at this point. I don't think with our current resources, financial and staff, that we could take on the transformation work full stop. I don't think we're equipped to do that right now. And we also have a board structure that is focused on regulatory type decisions. So again, transformation work is much more, we do have a policy director, Elena, she's wonderful, but she informs our regulatory work. The transformation work is much more of a policy and kind of thought effort. So it's not that, I think, could we do it? Yes, but we do not have the resources or the money. Like if you were going to require us to do even the service line analysis, and I think Board Member Holmes testified to this in the Senate, we would need resources to do that analysis in a way that was actually meaningful and was giving the hospitals and the public the information they needed on why we were making our decision. I would view that analysis as duplicative of the work that AHS is doing, because they're already looking at how do you regionalize services and care? Where should services go? Like that is already being done at AHS. So if you were going to just take this and put it with the board, that would largely be overlapping with what I understand the work that AHS is already doing. And I don't, same to what Devin testified to, I haven't seen the transformation plan, so we don't even have a window into what is being discussed or planned. So again, it's more about where we are now. And I was trying to answer the chair's question. We're right now, I would not recommend transferring.
Yeah, I wasn't,
Yes,
just.
yeah. No, I hear what you're saying, but it's about resources, it's about staffing, it's about duplication, wanting things to be more cohesive, which I think we struggle with in this state sometimes, especially around health policy. So
Cohesive, that's the word I was
Cohesive.
looking for.
cohesive, right.
Okay. Thank you.
Thank you so much. Thank you. Appreciate it. Thank you.
Alright. Go off of, wait, yes.
I'm just looking at the Agency of Human Services Office of Healthcare Reform and their most recent healthcare system transformation report. And I'm not sure if it would be useful maybe to have someone come in and review it with us.
Yeah, I think we're gonna get an update from them soon. Okay. Thank you.
Thank you, bye.
We can go off of live and we're back.